Good evening, everyone. Now we're going to start the case session 8 entitled Complex PCI. I'm Dr. Cheng-Chun from Taiwan. It's my great pleasure to co-chair with Kenji Wagatsuma from Japan. So today we're going to have 6 presenters from all over the world and very diverse topics. So I expect it would be a very exciting session. So now we have 3, maybe 2 distinguished panel from Russia, Dr. Sozykin, and from Hong Kong, Dr. Wong. So now I would like to invite the first presenter, Dr. Ting-Wei from Shinkong Memorial Hospital, Taiwan. The title of his presentation is a case of left iliac vein total occlusion complicated with stuck end of fracture stent. Dr. Wei, please.
Good evening, everyone. Nice to meet you all. This is my topic, and I have no conflicts of interest to disclose. The patient is a 69-year-old man who presented with typical post-thrombotic syndrome, left lower leg swelling, stasis ulceration, and black discoloration for over 1 year. He was diagnosed as deep vein thrombosis in other country, and the CT there show a iliac compression syndrome with left iliac vein total occlusion. He was referred to our hospital, and this is the venography from his left popliteal vein. There was some partial thrombosis over his superficial femoral vein, and the major flow coming from the collateral beside the SFV, like this. And over the common femoral vein level, there is a huge sausage-like collateral from femoral to another side femoral. And the left side iliac vein was totally occluded. And inside the CTO body, there was some complex connection. Maybe there were 2 possible routes for the CTO. One is yellow and the other one is red. I tried the yellow route first, and this is the result. The catheter shot show this might not the correct route. This might be just another collateral, maybe a zygous vein to the IVC. So I shift to red route. Before I change to the red route, I changed my approach side first because of very poor backup support. I approach from the right internal jugular vein and the left common femoral vein. This is the venography after changing approach site. And we can find the CTO entry was quite clear over here. I start my intervention from the common femoral vein. And as you see, the vessel course is very tortuous, like the video. I tried to perform bidirectional approach, and I used multi-purpose guiding catheter with guide liner support and balloon catheter anchorage. And after some efforts, the wire overlapped. And I tried to do card technique and a double balloon technique, and finally, the wire successfully crossed the total occlusion and go into the IVC. After wire was externalized, I tried to do balloon angioplasty and try to deploy a stent, a self-expandable stent. This self-expandable stent was characterized by his high radial force, high crush resistance, and high flexibility. But in the halfway of stent deployment, the stent was completely stuck and fractured like this. And this is the rotation angiography. So how to bail out this kind of situation? I tried first method is to do balloon angioplasty from the contralateral side, but this method did not work. So I tried the second method is to do manual retraction like this. And this is the video. Of course, I give the patient some sedation and analgesia first. Yes, I remove the residual stent like this. And after I retract the stent, the strut over there was completely destroyed and the balloon cannot cross anymore. So I use another stiff wire to cross the strut over here and successfully externalized from this catheter. After I pull through this wire, the backup was quite strong and I successfully cross the balloon like this and do balloon angioplasty. Then I try to cover another self-expandable stent over the old one, like this one. This is the final venography. The venous hypertension was relieved well, and the patient's symptoms recovered soon after the procedure. So discussion, what's the cause of stuck stent? I think there might be two possible reasons. The first is iliac compression syndrome. There might be some spur formation inside the vein, total occlusion part, and this will compress the stent. And the second reason is the tortuous vessel. The tortuous vessel will make some bending or torsion stress over the stent. So my conclusion is we experienced a rare complication when deploying the self-expandable stent in iliofemoral vein. And how to bail out this kind of situation? First, do balloon angioplasty from the contralateral side. And second, do manual retraction. Thanks for your attention.
Thanks, Dr. Wei, for this very interesting peripheral intervention case. Any comment from a panel?
I have a question. Thank you for this such an interesting report. But I'm as a cardiologist, I'm interested in anticoagulation treatment and their bleeding risk. And what did the patient take all medications after this first surgery, and what was the cause? I didn't catch it.
Yes, actually, this patient was referred from other country. It's from Palau, and he took regular anticoagulation such as warfarin for over 1 year, but his defense thrombosis symptoms was on and off. So this time, the local doctor suggest him to do peripheral intervention to relieve his venous hypertension forever. Thank you.
Oh, okay, thank you.
So, Dr. Wei, after the second stent, it seems that there's still a focal, very tight segment. Am I right?
Yes, of course. I think it might be the destroyed stent strut, or the second possible cause is the spur. But I cannot make sure which one is the true situation. Yeah, I do aggressive balloon dilatation, but there is still a local.
So is it undilatable or recoil?
Undilatable.
Undilatable. So did you do any other image study to check the potential cause of this undilatable situation?
Yes, but because of the limited economic of the patient,
Okay.
so
okay.
I can use the self-pay IVUS.
So Dr. Wei, could I ask a question? So so the stent, the self-expanding stent actually fractured when you deploy it. And you think that that may be related to the tortuosity of the vein. So how about after putting the second stent, there's still risk, a very high future risk of stent fracture, am I correct?
Yes, thanks for your great questions. Because first time I want to deploy the stent accurately just at the IVC, ostium. So I put the stent from the common femoral vein. And the common femoral vein was very tortuous, so the stress was very high. And the second time I built out this kind of situation, I put the stent from the IVC side. So IVC was quite straight. So no more problem.
So short question, have you a similar experience in artery, PAOD? Is this the first experience to have a fracture of self-expandable peripheral stent?
For me? Yes,
yeah.
My
or any reports?
I read some. I read Dr. Hirano's lecture. He has lots of PAOD experience, and I have only one case experience, and I learned most of the bailout from him.
Okay. Thank you for your very interesting case, and we're going to move to the second presenter, Dr. Igor Buzaev from Russia. The topic is Echonavigator hybrid visualization modality for Atrioseptostomia with modified stent in patient with severe pulmonary hypertension. Let's welcome Dr. Buzaev.
Good afternoon, colleagues. The topic I want to discuss with you is about our eyes improvement in the cath lab. It is about my visualization. The problem is that fluoroscopy visualization is limited because it makes the shadows from the X-ray positive materials and they drop the shadows on the detector. But if we need some soft tissues, flows, or for a prolonged time without contrast, the X-ray is limited. What if we need to see more than X-ray picture at the moment? To solve the problem, usually doctor looks to the fluoroscopy and then change the view to the echocardiography, for example, picture. But it is not very useful because sometimes we need to see relationships of our instruments, catheters, wires with soft tissues and flows. So we see the instrument without soft tissues on fluoroscopy, but we see the catheter as a small point or circle on the echocardiography. So, and it is sometimes hard to understand what part of the catheter is at the moment in the echocardiography picture. So in atrioseptostomia with stent for pulmonary hypertension, echocardiography shows us the septum, but fluoroscopy shows us the entire stent. But we are limited to understand the relationships. To solve this problem, engineers invented a hybrid visualization. The principle is that the transesophageal probe is X-ray positive and it has the direction markers, and you can see the direction that can be detected by fluoroscopy, and device can calculate the direction of the ultrasound beam and put it over the fluoroscopy. Then the plane of ultrasound picture projects to fluoroscopy in real time to show ultrasonic picture over the fluoroscopy. And this is our case as a patient with idiopathic pulmonary hypertension. She has syncopes despite of 3-component specific therapy. Regarding European guidelines, atrioseptostomia is one of the treatment options for this kind of patients. And on echocardiography, we can see the right hypertrophy, the paradoxal movement of the ventricle septum, and left ventricle have the specific banana shape. So the patient had a high right systolic ventricle pressure, about 120 millimeters, and we done the operation under local anesthesia with fast cut sheath. We took the 8.5 sheath, and we used it to make transaptal puncture under the transesophageal guidance. Then we made balloon predilation with 6 millimeter balloon and at 8 atmosphere, and we used custom-made stent with 7 millimeter loop over the palmats 9.0 times 30 strut in the middle of the stent. So we make the loop around the stent to prevent and make this type of the sand clock shape. And then we deliver this kind of stent inside the ASD occluded delivery system, as usual, to make the ASD closure. And this is how we make the stent modification to limit the whole side and make the sand clock shape. And we put the suture under the one stent strata and make the ring to have the node around 7 millimeters in diameter. The problem was to put the middle of the stent directly exact at the septum, because when you see it on ultrasound, you will see only the point of the stent. You don't know what kind of point of the stent is it. And if we see the fluoroscopy, we see only the X-ray picture without seeing the septum. And the Echonavigator is a unique benefit because it combines fluoro and echo in real time. In this picture, we can see the relationships. This is the septum, and this is our instrument. And we see the X-ray picture and ultrasonic picture, and we can make good positioning of the stent. The position and fixation of the stent after that was perfect. You see the positioning of the stent on the X-ray. This is balloon expanding moment with this kind of loop, and this is the echocardiography picture. And the patient have a very good improvement of quality of life. She had no symptoms for 1 year, and the ventricle shape was normal after that. So hybrid modalities are very useful. It is magic when you do the Atrioseptostomia with stent for pulmonary hypertension, because echocardiography shows the septum and fluoroscopy shows the instrument. And my impression is that it is unique technology. It disburdens the brain to change the different modalities and makes mix of the different pictures on one screen. So thank you very much.
Thank you, Dr. Buzaev. As I mentioned, we have a quite diverse topic. Any comment? I'm not very familiar with these procedure. Any comment from a panel or from speakers?
This procedure is not very often. Limited use. We have in our region 1-2 cases per year.
Okay, so you combine to image to make sure the position of your device, right?
Yes. And it is very useful if you close PLD, for example, paravalvular leak. You can see the flow on fluoroscopy, rotate the C-arch to understand where is the leak, and then just put the wire. It is very, very, very useful for that. So it is one kind of another kind of magic of this device. I like it very much.
And how often do you use it in your like routine days, like your operations? Is it common?
So it is very easy to use device, and it is very useful to start with any easy procedures that doesn't need the navigation system. For example, you can use it in usual ASD closure just to have the instrument in your hand, just to understand the education curve, to learn on difficult cases. Then you can use it in difficult cases, and the most important are the paravalvular leak closure, because you can see the flow and you can dramatically lower the amount of the contrast, and you can very easy to choose the plane, the projection of the C-arch from one side, and you can use the instrument on fluoro by another. And another option is to make the septal puncture and transseptal stenting. This is another unique possibility of this procedure. So we use it in several cases in PLD, paravalvular leak closure, in atrial septal stenting, and for the closure of atrial septal defects, we use it just to have the experience working with this instrument to be easier in difficult cases, just to have the familiar with that.
Okay, thank you.
But it is very easy to use and very useful.
Okay, okay, Dr. Buzaev, thank you for your very interesting new technique. So because of time, we have to move to the next speaker. The next speaker is Dr. Sasapan from Malaysia. The topic is iatrogenic retrograde coronary aortic dissection during coronary intervention, rare but life-threatening. Let's welcome Dr. Sasapa.
Okay, so basically I'm Dr. Rama. I'm from Malaysia. I'm a cardiology fellow. So I'll be presenting on iatrogenic retrograde coronary aortic dissection during a coronary intervention. So I have no disclosures, and my case is a 59-year-old male with the routine comorbids as listed here. His index event was a non-ST elevation MR in February 2020, where the culprit vessel was a distal circ, and we treated it with a drug-coated balloon in this region. And then subsequently in this intervention, we planned to stage his PCI of the proximal LAD CTO because he was still symptomatic. His ejection fraction was about 35%. So as you can see here, the left main is pretty short, and the ostial LAD is almost subtotal, and the proximal LAD here is a CTO. And interestingly, the previously treated distal circ lesion with a drug-coated balloon, that was 2 months ago prior to this intervention, still looked diseased with almost 90% stenosis. So like any CTO intervention, we did a dual injection using a biradial approach with a second access using a left distal radial approach, as you can see here. So we studied the lesion. The collaterals were very good from the RCA here. And as you can see here, it was a very favorable lesion with a JCTO score of 0. So we started off with an antegrade approach using a Fielder XT and a fine cross. We tried few attempts, but we were not able to cross. And then subsequently, without wasting time, we decided to escalate the wire to a Gaia 2. And as you can see here, the Gaia second kept going into the subintimal plane here. And then subsequently, we decided to use orthogonal views. And while the wire was still in the subintimal plane, we redirected the wire into the true lumen. Basically, it was a wire-based ADR crossing, and we successfully crossed the lesion. And after crossing the lesion, then we pre-dilated all the way from mid-LAD to the ostial left main. And I would like to point out in these two scenes here, as you can see here, while I am pre-dilating my ostial LAD, my guide was actually quite deep, almost sitting on the carina and hitting at one of the tightest segment, which was the ostial LAD here. There was no cine taken in between. The subsequent thing that I did was I used the same 3015 balloon, and I pre-dilated the ostial all the way to the ostial left main here, up to 16 atmospheres. And then subsequently, I took a cine. To my horror, the entire left system is dissected, as you can see here. The dissection also extended beyond the ostium into the aorta here. So the flap was almost less than 40 millimeter or 4 centimeters. So effectively, it was a Dunning class 2 retrograde dissection. So at this point, the patient within minutes started having chest pain. There was hemodynamic compromise needing inotropic support. And our nearest cardiothoracic surgeon was 3 hours away. I mean, my hospital does not have an in-house cardiothoracic surgery services. So we had no choice but to stent the ostium in order to save this patient. So we had to plan. So at this point of time, we had a dissected left main LAD and a circ. So we needed a bifurcation treatment strategy. So we started off with a provisional approach, and we did a rapid IVUS pullback, basically for vessel sizing. As you can see here, the left main was about 4.25. The distal vessel was about 2.66. Also to note that the point where we crossed the CTO using ADR, Y-based ADR here, our wire was actually in the false lumen here, and then the true lumen was here at the 12 o'clock. But however, we made sure that the wire is definitely in the true lumen from here to here and here to here. And then, of course, we had to treat the distal circ lesion before we could actually do the left main LAD, or else getting a stent into this circ is going to be very challenging. So we pre-dilated the lesion, and then we stented with a 2548 here. And surprisingly, after stenting, the dissection flap over the circ seemed to have sealed off here. And the flow was almost symmetry. And then we proceeded to tackle the left main LAD. So we stented from mid to proximal with a 3028, and then from the proximal all the way to the ostial left main, overlapping here, as you can see here. And we also post-dilated the stent, and then we did a pot and a flare here, as you can see. And then this was the shot after that. It looked good with a Dimitri flow here. Can't really see much dissections. So we were quite happy. Then we proceeded with the IVUS post-stenting run. And as you can see here, the MSA over the left main was about 10.5. The LAD was about 9.18. In fact, the overlap segment was well opposed here. Then IVUS confirmed no stentage dissection or malappositions. So we were quite happy. And then we pulled out the circ wire and took a cine. And to our horror again, the dissection that was over the circumflex here started reappearing. And this time it was worse than earlier. It was about type B dissection with a TIMI 2 flow here. And within minutes, patients started having chest pain and became more symptomatic. And at this point, we have a compromised side branch. Obviously, we needed a second stent to bail out the side branch. So we looked at the angle. The angle was about 70 to 90 degrees. So we opted for a T-stenting strategy here. So we wired back, and then we used a small balloon to open up the cell struts. And then we delivered a stent, and we chose a size just enough to overlap with the previous stent, and the proximal end parked just at the ostial circ, and we delivered. It was a 275/20, and then we did a kissing and a pot, and this is our final result here. I hope you guys can see clearly. Okay, here. Okay. So my discussion points I would like to point out is, I would also like to know what the panelists think that could have caused this dissection here. But from what I think, whatever caused the complication here in my case could have been a catheter-induced trauma or a balloon inflation over the left main. Of course, forceful contrast injection and harsh movements are other causes. Treatment per se is of course surgery, but especially in Dunning class 1 or class 2 dissections, we can actually use ostial stenting as an alternative. So the other thing I would like to point out is the rationale of using T-stenting for bailout. It is interesting that you can actually start off with a provisional stenting and convert to a T-stenting later on to bailout. The steps are also fewer compared to other bifurcation techniques. I mean, you only need to recross once. There's no significant overlap of stents and does not compromise the integrity of the main vessel. And interestingly, you can also use a conventional optimization technique such as your KBT and POT to improve the geometry further. And my conclusion will be this complication can be prevented. Ostial stenting is an alternative to surgery, and T-stenting is an simple and effective technique to bail out compromised side branch, especially in emergency. Thank you.
Thank you for this very interesting case, and congratulations for a successful bailout of this very tough situation. Any comments from panel?
It's a very interesting case, and seems like I don't know, like it's a difficult decision, to be honest. Like the main problem, you can cover the left main stem, but I don't know the aortic root. How much concern about is it involved the aortic root, because it seems like extended dissection. So like it's you brave guys. He sorted this patient.
Yeah, it was a very brave decision, and we had to do it at that point of time. But of course, there were many studies showing that as long as the dissection doesn't extend beyond 40 millimeters, we could still stent at the ostium, and most likely we may not need a surgery subsequently. And we followed up the patient. A CT angio was done, and the dissection seemed to have sealed off from the scan subsequently.
It's very good. Well done.
Yep, thank you.
Yes, I think it's sometimes encountered, especially for complex PCI. You can cause a trauma at the ostial lesion and then cause a dissection. So based on my personal experience, I think if the dissections do not extend very far, I think it's quite safe. You can just seal the entry and keep the patient closely observed. Okay, so we're going to move to the first one. I would like to invite Dr. Wagatsuma to introduce the next presenter.
Okay, so let's move on to the next paper. Next paper is entitled How to Treat Recurrent Angina with Previous CABG and 17 PCIs. Dr. Al-Bassam from West Middlesex University Hospital, United Kingdom. Dr. Al-Bassam, please.
Yes, thank you very much. Basically, this guy is like to present it is, yeah, I don't have any disclosure to start with. And yeah, basically this 60 years old gentleman with history of recurrent angina is on 3 anti-anginal medication, including bisoprolol, isosorbide, monoarterate, and ranolazine. And poor guy had a previous CABG, but which is complicated by blocked left internal memory, so we have to stent like everything, the LAD to the left meristem, which has happened 4 years ago in 2015. And he was basically having these things of recurrent angina as represented every 6 months with blocked SVG and to the RCA, and also like recurrent ISR on the SVG to the CERC. He had more than like probably 17 stent total, like per his presentation. So, and this is his angiogram, and then you can tell me about what do you think, guys. That's his video. That's the SVG to the CERC. And it seems like this is the native, which is LAD, left meristem stented, and CTO to the CERC. Clearly here, if you can see. Yeah. So that's all the ISR segment here, which is keep having these recurrent every 6 months represented to our cath lab. And that's the LAD, left meristem stent, and this is the CTO to the CERC. So this is our diagnostic angiogram, and you can see the ISR here on this, the CTO to the CERC. And what we decided to do, we decided to do different things in this case, because he was having ISR on the left on the SVG segment here, and he was having recurrence. So we decided let's open the native CERC, even the native CERC, which is being gelled by the stent here on the left meristem to the LAD. So we did a double radial approach, and we use basically Cyan blue and then Corsair, and then for the gelled left circumflex we have to open the CTO, but we're using Confianza wire just for proximal cap, and then switch to Gaia 2, and then pass the distal cap also with Confianza, and then we prepare the lesion with 2 millimeters and then 3 and C. And this is, we use the microcatheter, and also we use the that's how we progress with wire escalation using Gaia and Confianza. And then we prepare the lesion, and then we did a kissing balloon. Finally, we use also guide liner to support us just to deploy the stent. And also we optimize it with kissing balloons. And this is the final result. And that's the previous stamp of the SVG here, the insertion point. So, I mean, we followed this patient even after 1 year, and even like he was very well, and he doesn't have any angina. So we're quite pleased with that. So basically the discussion point here, what do you think, like if we're gonna do PCI to the SVG ISR again? And do we have any other revascularization option in this case? And like, which one do you prefer, opening a gel CTO or opening recurrent SVG ISR? That's to the panel. I'm just asking the panel. So take-home message. So double radial approach is sometimes useful and safe to consider even for complex CTO, and also it's possible to open the gel CTO by using microcatheter and guide liner support. And sometimes you have to decide to open the native CTO, like in this case, as the SVG is not like a very good prognostic, and with previously like stents and loss of stress in his case. So thank you very much. I'm happy if you want questions, anything.
Thank you very much, Dr. Al-Bassam. It's a quite tough case. So I'd like to make sure after that the patient is now okay, no recurrent angina, and
yeah, he's like we stented his like in 2018, and we've seen him like until like last year, 2020, and he was fine. So more than 2 years. But the main problem, like in his case, was coming every 6 months with angina, and the SVG, and which is not like, because it's all SVG. We know that the atherosclerosis process quite fast and will block the stent. Like, I mean, that's why he had also more than like how many strut layers. So thus he will be more at risk of stent restenosis. So so that's the main. So we decided to open the CTO circ, which is, it took us about 1.5 hours, but at least he was fine. Even after 2 years, he was fine.
So you mean the 17 PCI, all of the PCIs are for the SVG bypass graft?
No, also to the LAD, but he got, because he complicated, the Lima unfortunately has been blocked acutely after the cabbage. So that's why he was complicated with the STEMI. So we have to open the LAD in 2015, and then we crossed the left meristem. But I mean, the SVG, he had more than 5 procedures on the SVG, and like we implanted more than like 10 stent and then double strut layers. So that's why he was having like recurrent ISR every 6 months, and then we decided this time differently. Yeah.
Okay. So any comments or question from the panelists or?
Yeah, could I ask a question?
Okay.
Yeah. I think it's an excellent case. I think it's very fair to open up the circumflex. May I know that which technique you use at the left main bifurcation? I mean, do you actually implant a stent up to the osteocircumflex?
Yes, we implanted to the osteal, and then we basically made also kissing balloon inflation. So it's like, but we haven't added any further stent to the left meristem LAD. It's basically to the osteal circ, like we used like 3 stents to cover the CTO segment.
Yes, I see. That's excellent, I think. But the next thing to be worried would be the osteocircumflex, which is usually the site where most frequently the next ISR will be. But I think because you basically have no choice if there's recurrent ISR within the SVG graph. So the only thing you can try to do would be this kind of stenting at the circumflex. Is an excellent case.
We stented the osteal circ. I agree with you. The problem is the nidus of the next ISR. But at least he passed 2 years. I mean, he was having 6-month ISR again in SVG. So we decided that we might give him longer this time, the native. And also his LAD was fine since like 2015. So we thought we might have better native stenting procedure rather than SVG.
Yes.
Mr. Chairman, I have a short question.
Sure.
Dr. Amir, it's a very, very rarely complex PCI. It's congrats here. If you meet a patient with a full jacket artery, heart, which you prefer, use in-use stents or use drug-eluting balloons?
I mean, in ISR segments, we we are happy to do DEB because this is the recommendation. So drug-eluting balloon, it's sometimes enough, but if there is no progression, like extensive, like distal to the stent or proximal to the stent, so I think DEB is quite reasonable. Otherwise, we will have to add double layers, or like this will also make complication in future more. So I mean, if it's possible to use DEB, yes, we first choice will be drug-eluting balloon rather than stenting. But this guy, he's CTO, so we have to stent anyway. But I mean, the next step, if you got an ISR, I think we will just DEB.
And if you work in by CVG, how many often do you use distal protects for avoids embolization or something?
To be honest, yes. I mean, that's the recommendation European, like this year and last year. But it's not like, and it's still like we're doing like normal wires, unless there is a friable like segment, and we are concerned, then we use filter wire. But still, we use normal wire like BMW and these wires. I mean, if it is straightforward, there's VG. But if I mean the recommendation to use filter wire, European recommendation, use filter wire and SVG to prevent any thrombosis. But if you think like a straightforward procedure, I mean, some will depend like on the case. If it is friable and you think like, oh, there's a thrombus, little thrombus, then filter wire, of course, be recommended.
Thank you.
One thing I'd like to make sure you did a double radial approach. Which kind of guide catheter? 6 French, both 6 French?
Yes, we use 6 French EBU 3.5 for the native, and we used AL 0.75 to the SVG as a guide catheters, both guide catheters.
So you prepare a retrograde approach?
Yes, we prepare retrograde in case as a complication, in case if there's any complication.
It's a quite tough case. I also often perform that double radial approach for complex CTO, but we usually use a 7 French guiding catheter because if we use a 6 French guiding catheter, some special technique cannot be performed, limited enrollment diameters. For example, Al-Bassam guided or something. So
yeah, that's very good. The main thing is because we use the radial approach, so we said 6 French as we're planning to do antegrade. I agree with you, but I mean, there's a sheathless guide. Sometimes we use it as a 7 French radially, and that sometimes we can use it.
Okay.
In like a bailout procedures. Yeah.
Okay, thank you. The time is limited. Thank you very much.
Thank you very much.
That's why the manager of clinics don't like CTO, but doctors likes, because it's very interesting and need more device, more guide wire and all
yeah,
that.
Exactly.
Okay, let's move on to the next paper. Next paper is entitled Longitudinal Stent Deformation Caused by OCT Provoke in Percutaneous Coronary Intervention. Dr. Kao from National Taiwan University Hospital, Taiwan. Dr. Kao, please.
Okay, good evening, ladies and gentlemen. I'm Dr. Ting-Wei from the National Taiwan University Hospital. In conjunction with Dr. Su, Dr. Tung, and Dr. Huang from Taipei Veteran General Hospital, we are privileged to present this case. The title is Longitudinal Stent Deformation Caused by OCT Pullback in Percutaneous Coronary Intervention. And we have nothing to declare. So this is a 57-year-old gentleman suffered from the apparatus on hand for 4 times this month. The most recent episode occurred 48 hours ago after drinking alcohol and lasted 20 minutes. Radiating to throat, the pain was accompanied by sweating and vomiting. Underlying, he's a heavy smoker and a chronic drinker. At the ER triage, the physical examination documented no cardiopulmonary embarrassment. Lab came back suggesting normal CT-MB and high troponin T level. The EKG, however, documented normal sinus rhythm without ST elevation. 2 days later, the patient underwent treadmill exercise test, which was terminated at 6 minutes due to the onset of symptomatic ST elevation at inferior lead. Emergent PCI was thus initiated. We assessed from the right femoral artery, 90% discrete stenosis at middle right coronary artery was demonstrated, and OCT illustrated local plaque rupture. The RCA ostium was engaged with a 4/7 French guiding catheter, followed by fielded guide wire reaching distal segment after piercing through the cochlear lesion. Due to high thrombus burden, aspiration with pronto catheter in conjunction with the IC administration of the loading dose agrostate was performed. After confirmations of the lesion status and the landing zone by the OCT, the Sierra drug-eluting stent was deployed uninventively. No remarkable finding was noted during the OCT pullback. Subsequent instant post-dilation with Ikazuchi and Akufos balloon was strenuous to cross over the primary stent. The OCT reassessment at this stage exhibited a distal longitudinal stent deformation. Fortunately, eventual TIMI-3 flow was realized. The patient was discharged 2 days after this procedure under stable conditions and remained asymptomatic at 2 months of the outpatient follow-up. And the final diagnosis was single vessel CAD status post drug-eluting stent to middle RCA while complicating the LSD. Discussions. In this study, we described the first case of LSD due to the OCT pullback, and we would like to discuss this condition. So longitudinal stent deformation is a rare but catastrophic complication. The literature also suggests its association with unfavorable prognosis. The cause is mainly because of either incomplete apposition of the primary stent or mechanical compressions of the subsequent instrument. The risk factor includes suboptimal stent platform design, complex lesion factor, and insertion of the secondary devices. Epidemiological report of LSD varied from study to study, owing to the sensitivity of the different diagnostic modalities. In early time, where LSD was under-recognized and was considered to occur only with promise elements, possibly caused by its peak-to-peak design. Subsequent reports nevertheless document LSD on other platforms as well, marking LSD a universal complication in all settings. The construction of the stent technically determines its resistance to external pressure. The rigidity of the stent is dependent on the quantity and mechanical profile of the connectors that chain the individual components as a whole. From the manufacturer viewpoint, the strength of the stent is challenged by standardized band trap compression and elongation protocol during the fabrication process. Nowadays, the modern balloon expandable stents are fabric composed of thinner strut, fewer connectors, and caboid alloy, thereby enhancing tractability, conformability, and flexibility, while in the expense of compromised longitudinal axial strength. Besides, location and complexity of the target lesion also predicts the LSD risk. Literature suggests the left main, bifurcation, and ostium are among the hot stop for LSD. Moreover, the OCD inclined to take place in the presence of greater arterial calcific plaque burden. In conjunction with the lesion factor itself, managing such lesion of interest often indicated the use of supplementary equipment. So extra touching of the daughter and motor apparatus has been sustained as a statistically significant factor for the LSD. So whether or not LSD would jeopardize cardiovascular prognosis is still controversial. So in theory, the rinking of the primary stent by the LSD leads to inadequate plaque coverage, excessive hyperplasia of the tunica intima, and further develops a thrombogenic microenvironment. However, interestingly, the clinical outcome is not altered. The Dutch PS trials reviewed 9 patients who experienced LSD during PCI, whereas none of which endorsed any detrimental clinical incidents. In addition, Dr. Ri and colleagues reviewed 350 lesions from the multi-center pooled DES cohort. Not only had predictors of long-term outcome been discovered, but they also documented comparative, albeit numerically higher rates of all-cause mortality, MI, repeated revasc, and target organ failure due to LSD. So regarding this case, the cochlear lesion is neither situated at LSD favorable position, nor heavily calcified. The Stent platform with CS CRS was also reported to be relatively safe. So etiology for this LSD incidence could therefore be attributed to excessive embellished intervention, including thromboaspiration and OCT for 3 times. Ladies and gentlemen, this is our conclusion. The LSD is a rare yet clinically noteworthy complication of PCI. So introductions of the accessory devices such as OCD predispose the patient to experience LSD during the procedure, and the determinations of the long-term prognosis await further investigations. Thank you all very much.
Thank you for a nice presentation, Dr. Kao. We sometimes experience this kind of stent deformation. Any question and comment from the panelist or presenter? How about Dr. Wong?
Yes, Dr. Kao. So did you experience any difficulty when you pull out the OCT catheter after your post-stenting pullback?
Well, unfortunately, we only experienced some resistance during the pullback. And while it is a common experience in the procedure, this is the first time that we encounter the LSD during the OCT pullback. Thank you for the comment.
Yeah, I think the lesson to learn would be if you experience any even very slight resistance when you pull back any secondary devices, then try not to use any force. Then I think this is the lesson to learn.
Yes, I agree with you. Thank you.
Dr. Gao?
Yes?
Is the longitudinal shortening occurred at the bending portion of the vessel?
Pardon, please?
I mean, is the longitudinal deformation occur at the very acute bending portion of the vessel?
Yes, it occurs at the bending portions, yes.
Okay. So any resistance when you try to deliver the OCT catheter?
No. When we delivered the catheter, it was smooth. And however, the resistance was experienced at the pullback stage. Yes.
Okay.
Actually, this kind of longitudinal deformation occurs during this kind of imaging device, such as so-called short monorail type. Not only OCT, but also IVAS or something.
Yep.
Yeah.
So we need to take care of this kind of situation.
Yeah.
And in general, you implanted a Zion stent for this patient. Zion
yes.
is comparatively not so easy to deform. For example, the more softer stent and
yes.
Science is 3-linked and almost peak-to-peak linked. It's a quite stiff stent. But
yes.
Some kind of stent linked, not offset peak-to-peak. It's quite easy to deform.
Yes.
Okay. Any question, comment? Okay. So thank you very much, Dr. Kao.
Thank you.
So let's move on to the last paper. Last paper is entitled Double Jeopardy with Guide-induced Left Main Coronary Dissection and Radial Perforation with Successful BAT Technique and Reverse Clot Stenting. Dr. Afijirawat from Huramongchokrao Hospital, Thailand. Dr. Afijirawat, please.
Okay, good evening to from the Thailand. I am Dr. Wong Afijirawat from the Huramongchokrao Hospital. Okay, today I would like to present the case of double jeopardy with guide-induced left main coronary dissection and radial perforation with successful BAT technique and reverse clot stenting. I have no disclosure. This is a case of the 45-year-old man with a history of the chronic heavy smoker. He presented with the chest pain for 2 days accompanied by diaphoresis. His vital signs and physical examination were unremarkable. The cardiac enzyme was showed the significant rising of the high-sense troponin, so diagnosis of non-STEMI Wattman. The ECG showed a non-significant no ST elevation. So we brought him to the cath lab. You can see at the IO caudal view that the significant stenosis of the proximal LAD is about the 70%. Sorry. Okay, you can see the right is small and non-dominant vessel. So the third is the dominant vessel and no non-significant stenosis. Okay, so we plan to perform the PCI to the proximal LAD using the sequence sheet. This is not my routine approach because the 5 and 6 cent inflict sheet was run out of stock. So we use the sequence EBU 35 and the run to Y in LAD and Retrograde Y to save the diagonal one. And we paste the T.0 by 21 millimeter CES stenting at the proximal left main. Okay, and we post-dilate with the 3.25 by 12 millimeter, and the procedure was done without difficulty. But when we perform the final angiogram, it showed the left main dissection that extend into the third, dominant, and osteomarginal branch. The patient developed chest pain at this point. So we immediately placed Y run through to the third and the Retrograde Y to the LAD, and we use the IVAS to confirm my Y position was in the whether in the true lumen or the false lumen. You can see at the inferior segment of this video, you can see the dissection flap is from the left main extend into the third osteo. This is a correlation of angiogram and IVAS. The dissection flap is from the left main into the third and impair the flow. And we confirm that my Y wire is in the true lumen. The different diameter of the left main is the 4.5 and insert was 4 millimeter respectively. So we immediately stenting to the left main for the proximal control dissection with the 4.0 by 72 millimeter sotalolomous imaging stenting, crossing from the left main to the third. Okay, and after we place the third left main stenting, the flow was restored and the dissection is dissolved. At this point, you can see the LAD osteo show the significant stenosis, and we confirm by IVAS that had a significant plaque at the osteo to proximal LAD. So we need two stenting at the left main LAD and third bifurcation, and using the two large balloon. So the guiding with the 7 French guiding was used due to we plan to the kissing balloon inflation. But the patient developed a severe radial spasm, and when we advanced the guiding catheter, the radial showed the perforation at this point. So we use the BAT technique with the Retrograde Y, the 2.0 by 10 millimeter compressed balloon to advance the catheter to the coronary ostea without difficulty. And we continue the procedure. We place the CES stent 3.5 by 15 millimeters in the left main and to the LAD using the Coulomb technique, and the kissing balloon with the 4.0 millimeter insert and the 3.5 in the LAD. And we put the left main with the 4.5 by 8 in the left main stent. This is show the final angiogram after we kissing balloon and the pot in the left main. The flow was TME3 flow, and you can see the osteo of the OM may have some pinching stenosis, but I think that the TME3 flow and no other dissection. So we had planned to end the procedure at this point. And the radial angiogram after procedure show no perforation, so I think from the tamponade effect from the guiding catheter we use. So the discussion, the catheter-induced coronary dissection is rare and caused by non-coaxial of the catheter and coronary ostea. It may cause devastating event if the flow is impaired and delay of the treatment. Also, the radial artery perforation is not uncommon situation, especially when the last side of the guiding catheter is used. In this case, we perform the left main stenting first to alleviate the patient's symptoms and then change to 7 French guiding due to KBI was planned. Unfortunately, the 7th French guiding was also caused the radial perforation and rescued by the bad technique. However, the patient symptom is okay, and we discharge him at the tomorrow. As we follow up him at the 6 months and 3 months, and he feeling well until now. The catheter-induced left main dissection is rare, but the potential life-threatening. Keep calm and early intervention is the key to save life. Be careful of advancing of the large bore guiding catheter via radial artery, but pre-treatment with vasodilating agent may be helpful. Okay, thank you.
Thank you very much, Dr. Fijirawat. It's a quite tough case, and I'd like to make sure why you change guiding catheter 6 French to 7 French.
Because I think to use the 2 balloon, that's the 4.0 millimeter and at least 4 in the left main. So I think the 6 French catheter may have the stuck or the difficult in advance the balloon to the coronary. So I think we need to change the catheter to the 7 French.
Maybe you should continue by 6 French. Most of the technique can be performed by 6 French, even the 2 stent strategy. Okay. Any comment or question from the panelist?
Sorry, Mr. Chairman.
Yeah.
Okay. Okay, go ahead. Go ahead.
Okay. Well, I think one comment is that if you do need a larger hole, a larger bore guiding catheter, and this radial artery is too small, the other option is to use the second guiding catheter, so-called ping pong guiding. You can engage left main with 2 guidings, then you can deliver any device simultaneously without any resistance. Try to avoid the oversized guiding catheter. Trauma sometimes could be very severe.
Okay, thank you for your great comment.
Regarding the bailout situation, I remember you withdraw the wire, and then you find dissection of left main. Maybe you should check the angio before the guide wire remove.
Okay.
After that, the bailout technique will be quite easy. And also you put the stent from the rectum into circumflex. You leave the LAD. Maybe it's a quite difficult situation because some hematoma close the LAD. So if you can insert the wire both LAD and circumflex.
Yes.
After that, the bailout stenting will be easier.
Okay, thank you.
So time is quite limited. All of the presentations are quite impressive. So I'd like to close this session. Finally, I would like to express my sincere thanks to all of the presenters and panelists who are providing such interesting presentation in the discussion. I hope to see you again next year. Thank you.
Thank you.
Thank you very much.
Thank you very much.
Bye.
Thank you very much.